This webinar is organized by the European Regimen Accelerator for Tuberculosis, or ERA4TB. And next, Mohammed. So ERA4TB is a public-private initiative devoted to accelerate the development of new treatment regimens for tuberculosis. NICE, as a partner in the consortium, is responsible for various engagement and outreach activities, including this webinar series focused on health economics and health technology aspects of antibiotics and their research. The following topics have been covered so far as part of this series: the cost of tuberculosis treatment, drug development and access, and this is the third webinar and is focused on how collaboration can further access. There will be a fourth webinar in November on applying preclinical research to inform HTA decision-making. So for more information, please see the project website. Next, Mohammed. So this project has received funding from the Innovative Medicines Initiative to Joint Undertaking. The combined project has received funding from Initiative to Undertaking Grant Agreement number 853967. Also received support from the FPA and Global Alliance for TB Drug Development, Bill and Melinda Gates Foundation, and University of Dundee. Views expressed in these presentations are those of the project and of presenters, and not that of the IMI or the joint undertaking partners. Next, Mohammed. So today we have a great agenda where we will have different perspectives around tackling antimicrobial resistance and how policies were supporting that. So we have with us Sophie Cooper from NICE, who will talk to us about the NICE antimicrobial subscription model. Sophie is a senior scientific advisor within NICE and leads on NICE's contribution to the UK's antimicrobial product subscription model, a pulse incentive which seeks to address the market failure of companies not investing in the development of new antimicrobials. We also have with us Alexander Hasis, who's a regional officer within the World Health Organization. He supports the WHO Regional Office for Europe in Copenhagen, where he coordinates the Access to Novel Medicines platform. And we also have Michael Anderson, who's the regional advisor at WHO and leads on the research on AMR accountability and antibiotic incentive alignment, contributing to global policy debates on antimicrobial stewardship and sustainable research and development models. Each of these speakers will speak to us and for a few minutes, giving us an overview of the work that they're doing and that has been done. But then we'll have time for a Q&A session at 1:40 p.m. UK time or 2:40 CET, and we'll have closing. So just some housekeeping. So we encourage comments and questions, which can be submitted by the chat our QA function by raising a virtual hand. If you require closed or live captions, you can do by selecting the live transcripts icon in the webinar toolbar for auto transcription. The webinar will be recorded and be hosted for external viewing. So without further ado, I will hand over now to Sophie Cooper.
Thanks, Fatima. Just checking you can hear me, given my tech issues earlier.
Yes,
good.
Loud and clear.
Good. Apologies if I'm looking in strange angles, everyone. I've had a webcam issue, so looking across multiple screens. So Fatima's already introduced me, thank you. I work in the science policy team at NICE, and I'm on to the next slide. For anyone not familiar with what we do at NICE, our purpose is to help practitioners and commissioners get the best care for people fast while delivering value for the taxpayer. And I'll allude to how we've done this for antimicrobials in this presentation. What I first wanted to do is give a bit of context about why we needed to do something different for antimicrobials. My screen is frozen. Bear with me. Have you lost me? Am I still here?
We can see you and hear you clear. And is
I
it
might
still
have
frozen?
I might have to abandon the webcam in order to, because everything's freezing. So just bear with
Okay, it's fine.
the rest of my setup. Sorry, my computer was frozen. I can see the slides. So I'm sorry that you can't see me, but I shall continue. So on to the next slide.
Sophie, sorry, the voice is just a bit muffled. I don't know if you could be closer to a mic or what the issue is now.
That's might be in a headset. Let's see if I can apologise. I did try and then tested the tech earlier when it's saying that's is the headset effective?
No, is the camera closed altogether? Maybe that would help because I can see sort of like a light. So maybe if you could close the camera, then see if that improves it.
Really?
Yeah, maybe try speak a bit and we'll see. Yeah.
Is the audio any better at all? Should I try switching to another
No, it
headset?
is a lot better. It is better. Thank you.
So the next question is, how do we determine the value of the subscription contract? So that's where NICE comes in. That's our bread and butter, is looking at the value of new medicines. And our assessment will place the product into one of 4 contract value bands as shown on the screen there. So that's the amount the company receive each year, regardless of how much their product is used. And the 4 value bands help us to differentiate between products of different value and reward them accordingly. But our traditional approach to valuing new medicines doesn't work for antimicrobials. So I'll explain a little our traditional approach in the UK in basic terms, so you can understand why we need to do something different for antimicrobials, not just on the payment model side of things that I've described, but also the evaluation. So on our next slide, in our normal approach, a company would set the price for their drug, and NICE uses health economic modelling to look at whether the benefits of the drug justify the price. And the way we measure benefits is in quality adjusted life years, or QALYs, which takes into account the quantity of additional life lived with the new treatment and the quality of that versus the best alternative. And we have thresholds to determine whether a drug is deemed good value for money and can be recommended, taking into account the opportunity cost of displacing something else in the system. And to drill down into how we look at benefits a little more, our traditional approach is to look at the direct health effects only to those patients who are ill and treated. Whereas, of course, the value of antimicrobials is so much broader than this. So coming back to that analogy about fire extinguishers, they have wider public health benefits to the whole population, for which the acronym STEADY has been coined. And I don't think I have time to go into the STEADY values today. I'll pick out enablement value as one, because that's sort of what I was alluding to earlier, is antimicrobials as the infrastructure for effective healthcare, because without them, so many other procedures simply couldn't take place. Is for a patient who's themselves at risk of infection, so organ transplants, any operation, chemotherapy. It's about enabling healthcare in other patients too in the system. So, for example, if you're treating a person with a really severely resistant infection, that can be really costly, because to reduce the risk of transmission, staff allocated to that person are unable to care for other people. So, by treating that infection, you're freeing up staff and resources to care for other patients. So, if we were to use our traditional approach of cost-effectiveness analysis to antimicrobials and ignore all of these benefits, we'd be routinely undervaluing. That's why we need this different evaluation approach and a different payment approach. So we couple a new payment model with a broader evaluation approach. And on the next slide, you'll see how we tested this new way of evaluating antimicrobials in a pilot. You may have heard of the pilot in England, under which Cephidericol and Cazabi now have been paid for using these new de-linked subscription contracts for about 2 years or more now. And this is a joint project with NHS England, the commissioner for the NHS, and it was part of one of our commitments under the UK's 5-year National Action Plan framework. And what we did in the pilot was we used this quantitative health economic approach that we normally do to estimate the value of the drugs in follies, but taking into account those wider public health benefits I described, these steady values. And we use that to then work out a monetary value for the contract. But what we learned was that there were really big gaps and uncertainties in the evidence base, and the outputs of the pilot are published on NICE's website, as with all of our guidance, and there's a whole section on all of the uncertainties and why the gaps and further research is needed into filling the gaps in surveillance and this kind of thing. But it made we realised it would be really difficult to do quantitative health economics on a product-by-product basis in the future. But a really positive finding was that when we estimated the value of these drugs in follies, using our economic modelling approach and then translated that into the monetary value for the contracts, it actually aligned with what we call the UK's fair share of the amount of money needed globally to provide a pull incentive for a new antimicrobial. And that's according to some published estimates, or the most recent published estimates by Kevin Outterson, that's linked on the page there, the slide there. I think he's actually just published some updated analyses. So he's done a great amount of work on the cost of bringing a product to market and what the global sort of pull incentive should be. Then we worked with that to look at what the UK's fair share sort of portion of that would be. So that alignment between our quantitative modelling of follies and the fair share payments supported our proposal to move to a more pragmatic evaluation approach to determine the value of the contracts to companies. So we're using a clinically based sort of points-based scoring system, a bit like a multi-criteria decision analysis, which importantly are anchored in the learnings from the pilot and give us this reassurance that we're getting value for money whilst also paying our fair share and enough to incentivize these products. So on the next slide, which might be my final slide, you'll see the evaluation criteria that we're using in the subscription model, which is up and running. It launched in August. You may not have seen much about it because all of the evaluations are sort of confidential while they're ongoing, but once the process has completed, NICE's outputs will be published, as we do with all of our guidance and outputs, and the contract value bands into which each product has been placed will be published as well. So once that's all concluded sometime next year, you'll be able to sort of see all of that in detail. At the moment, you can see linked on the slide there, you can just sort of see the methods we're using at the moment. So these are the 17 criteria, and the percentages down the side reflect sort of the relative importance of these different criteria. Some are sort of ranked more important than others, and a product score will be a weighted average across those 17. I just wanted to draw attention to a couple of points. So you'll see reference to the WHO priority pathogen list. I mentioned that our eligibility criteria for the scheme hangs on that, but it also carries the biggest weighting in terms of the score and informing the contract value. And it's really important that we incentivise products that address global unmet needs and don't focus only on our local needs in the UK, because the UK represents only 3% of the global market. So we can't fix this on our own. We need lots of pull incentives across the world. And we need all of these pull incentives in different countries to be aligned and pulling in the same direction and incentivising products in the same area. So we can create a meaningful commercial incentive on a global scale for developers. We do recognise UK unmet needs as well. You can see there's a criteria dedicated to that there. And the criteria fall into 3 buckets. Again, I won't go through them now, but the link on the slide there gives a lot more detail as to the evidence requirements and how products are scored under each of these, so you can understand what kind of evidence we're looking for these. So just to conclude, really, that we hope that this is a pragmatic and scalable approach to determining contracts for antimicrobials, not just in the UK, but in other countries, because it doesn't rely on really specific HTA and health economic expertise and organisations and infrastructure. As I said, we in the UK represent only 2 to 3 of the global market, so we can't fix the failures on our own. And we in NICE and NHS England, and particularly our colleagues in the Department of Health and Social Care in the Global AMR Initiative team led by UK Special Envoy in AMR, Dame Sally Davis, are actively engaging and collaborating with health systems in other countries to use the lessons learned from our experience to create the approaches that work in other jurisdictions. That's it for me for now. I'll try and fit some audio
Thank you, Sophie. There is a question in the chat if you could add the link to the evaluation of the antimicrobials. Thank you very much. And now we'll hand over to Alex to talk to us about the WHO Novel Medicines platform.
Thanks very much, Fatima. I hope you can hear me well. I've also had some technical difficulties. But yeah, thanks for inviting me. So today I'll be talking about the WHO Access to Novel Medicines platform. As part of the work of the Novel Medicines platform also aims to improve access to novel and existing antibiotics. Next slide, please. So what is the Access to Novel Medicines platform, short NMP? The NMP is a unique multi-stakeholder platform for dialogue. So the special thing is that the public and also the private sector, so including pharmaceutical companies, they can meet and work together and jointly identify actions to improve patient access to novel medicines in the WHO European region. What is the role of the WHO? The WHO is the secretariat of the Novel Medicines platform and acts as a neutral convener to ensure that all the different stakeholders have an equal representation and equal voice. Then the secretariat also facilitates meetings and also coordinates the technical work that is developed and produced by the working groups. Next slide, please. So the members of the Novel Medicines platform, as I said, so very diverse stakeholders, including 52 out of the 53 member states. The UK is also represented through NICE. Then we also have 25 non-governmental organizations, including patient organizations, 6 pharmaceutical business associations, and 18 WHO partner organizations, including the European Commission, EMA, then also the OECD and WHO collaborating centers. Now, the work of the NMP, we have 4 thematic working groups, and you see the different topics on the right-hand side. So working group is on improving the transparency of the work that the WHO Novel Medicines platform does. Then the working group 2 is on improving solidarity and strengthening voluntary collaboration. Working group 3 is on improving sustainability of health systems and also industry. And then the working group 4, which is of most relevance here, is on improving access to existing and novel antibiotics. Now, each of these working groups, they are chaired by a representative of the member state and also 2 vice chairs that are representatives of either an NGO or a partner organization and an industry representative. So here you see we also ensure this equal representations across the different stakeholders in the working groups. And the working groups, they have developed now proposals that are currently being implemented through the Novel Medicines platform. Next slide, please. So here in this slide, I give an overview of the different working chairs and the vice chairs, but I want to focus on working group 4 to improve access to existing and novel antibiotics. The group is chaired by the Public Health Agency of Sweden, and the vice chairs are the directors of the Global Antibiotic Research and Development Partnership and also the EMR Action Fund. The aim of this working group is to identify policy options for sustainable innovation and access to novel and existing antibiotics. Next slide, please. So the working group 4 has developed 2 proposals that are currently being implemented. The first one is a needs assessment and guidance for improving availability of existing antibiotics. Here, the output is to provide a landscape analysis of existing initiatives mapping antibiotic availability and the drivers of limited availability. and also to identify policy interventions that have been implemented to improve supply and assess their effectiveness. Now, the second project is to promote alignment of products and or company eligibility criteria for incentives to incentivize the investment for antibiotic research and development and access. And here, this one has also been spearheaded by Michael. He is our expert consultant for the working group 4 and has delivered also parts of the output. And I think Michael will now hand over and present the study on promoting alignment of product and company eligibility criteria. Thank you. So that's from my side, just a brief intro on the Novel Medicines platform and the different work groups. Thanks very much.
Great, thank you, Alex, and thank you, Sophie, for that introduction. So I will talk a little bit now about what's happening in relation to antibiotic research and development incentives globally, and also talk about some of the emerging findings from this research project that's part of the Novel Medicines platform. So as Sophie mentioned, the UK has led the way in terms of developing incentives to promote research and development of antibiotics. However, it could be argued that this may have only limited influence on the pharmaceutical industry because it's 2 to 3% of global markets. So other players need to get on board and develop their own incentives. And that was the rationale behind this project, in particular, trying to make sure that when other countries develop incentives, that they send consistent signals to industry. Because yes, whilst other national priorities may differ, at least sending consistent messages regarding priority pathogens or clinical indications or other criteria for companies to comply with in relation to access or environmental health conditions could help improve the efficiency of deployed incentives. Because with mixed messages and mixed signals, there's more likely to be disparate research and development initiatives that are less likely to result in successful candidates. Next slide, please. And I've already started to talk about this, but the UK isn't the only country that has developed incentives for antibiotic research and development. There are other countries that have implemented incentives such as Sweden, the US, Germany, France, and pilot initiatives in countries like Japan. And there's already awareness that there is differences in terms of eligibility criteria for specific products that may be within scope for these incentives. So there's already a kind of mixed landscape of eligibility criteria sending inconsistent signals to industry. So there's a need. One of the reasons this has emerged is a lack of guidance for countries in relation to what type of eligibility criteria that they should use. There is, of course, the WHO priority pathogens list, but beyond that, there is less guidance in relation to what other criteria should be prioritized. So that was the overall objective of this project. Next slide, please. To promote coordination and alignment of the different eligibility and evaluation criteria, not just for the products, but for the companies themselves, to understand what type of companies are eligible for these incentives, but also what conditions must they comply with to receive additional funding for these incentives, and to provide guidance to different countries as they develop their own antibiotic research and development incentives, but also as they aim to improve their existing incentives. Because in many countries, there are actually multiple different incentives, but they don't necessarily reach what Sophie referred to as the fair share, which is the recommended amount of incentive to have a meaningful impact on incentivizing the pharmaceutical industry in relation to their expected investments in antibiotic research and development throughout different stages of preclinical and clinical development. Next slide, please. So how did we go about this? So there are a lot of existing reviews of antibiotic research and development incentives. they haven't necessarily taken the perspective of identifying the explicit eligibility and evaluation criteria, but they have identified which different incentives exist and which country they've been implemented in and their specific design. So many of which I've been part of in the past. So the first stage of this was to identify all the existing reviews of antibiotic research and development incentives. So we conducted an umbrella review, which is a specific type of systematic review where you go over existing reviews. And then once we'd collated a list of incentives, we then complemented that with a review of grey literature, because you always have this issue with an umbrella review in that there's a lag. So by the time the review is published, it's inherently outdated. And then by the time you review the reviews, you're even more outdated. So we conducted a grey literature review of government documents, media reports, and we also used the AMR Research and Development Hub in Berlin. Has a book of, or a collection of different antibiotic research and development incentives that they use for their working group on antibiotic research and development incentives. So we also use that to complement our list. And once we identified each individual incentive, two reviewers independently identified eligibility and evaluation criteria by looking at the relevant technical documents and calls for funding for each individual incentive. And this was collated together, and a thematic synthesis was conducted to narratively describe this. Next slide, please. So, apologies, there wasn't 29 reviews. There were 29 incentives that were identified. There was 20 reviews identified. Apologies, that's a typo. So there were 29 different innovation and access incentives that were identified, and these are only specifically referring to pull incentives. So I'm not going to go into great detail about the differences between push and pull incentives, but a very brief summary: push incentives are investments in early stage basic science and preclinical research, where pull incentives target the end of the research and development pathway when antibiotics are due to reach markets. So there are often changes in reimbursement reforms or market entry rewards. So we found 29 different examples of pull incentives, and 19 of which were already implemented in the UK, Sweden, the US, Germany, France, and Japan, and 10 that were either proposed or under development from the US, Japan, Canada, Italy, Australia, Switzerland, and from the Commission. So there's lots of activity in this space. It's not just, whilst the UK has led the way in terms of they were the first country that had an operational pull incentive for antibiotic research and development, many other countries have followed, although in some countries they're more smaller scale pull incentives, like their changes to reimbursement reforms to allow quicker access to market or slightly higher prices, but they're not as necessarily well funded as the UK model. But I'm going to go through some examples of some of the different types of pull incentives that have been used or have been discussed, just so you understand some of the differences. However, there's many different types of pull incentives that have been used. I'm just going to focus on the three main ones that have been discussed currently. Next slide, please. Okay, so this is so in terms of our thematic analysis and our critical appraisal of the identified incentives, we identified the following factors. So I'll describe these factors to you, and then when we go through those three different types of incentives, I'll talk about some of the implications according to these different criteria. So these are, I suspect Sophie and other people from NICE that have worked on the UK incentive will recognise some of these criteria. Spoiler alert, the UK did have the most comprehensive product and company eligibility and evaluation criteria identified in our analysis, and that has influenced our thematic synthesis and subsequent categories that we use to appraise incentives. So the targeting high priority medical need, this is related to whether the incentive explicitly identifies priority pathogens or clinical indications with high disease burden. The relative effectiveness is whether there is any criteria related to how effective the new antibiotic is relative to existing treatments. The unmet clinical need is whether the antibiotic targets disease areas or clinical indications where there is often no or only limited treatment options currently. The innovative characteristics relates to whether a specific eligibility criteria relates to whether the antibiotic has a new mechanism of action or is a new chemical class, which could represent, is particularly valuable because it could result in further antibiotics being developed from that initial step change in innovation. The health system impact relates to whether there's any eligibility criteria related to how the dissemination of the antibiotic will impact the health system. So, for example, if it's a new antibiotic that can be given orally instead of IV, that could mean a lot more patients could be treated at home, which could reduce healthcare costs. And then other product characteristics was a catch-all for any other eligibility criteria that were outlined. Next slide, please. For company eligibility and evaluation criteria, there was much more discordance across incentives in relation to these. Antibiotic sustainability is whether the incentive had explicit criteria related to stewardship and prudent use of antibiotics. So, for example, some incentives required that the pharmaceutical company could not do direct consumer advertising, or required that the hospitals that were accessing the antibiotics needed to have a stewardship plan in place for that specific antibiotic. Patient access is related to whether there is any explicit access agreements required to receive additional funding under the incentive. So examples could include that the company needs to have stockpiles of the antibiotic over a certain period of time to ensure that risks of shortages are minimized, or that they needed to commit to providing equitable access across certain regions within the country across a certain time frame. The environmental health criteria that was seen was often related to whether there was conditions put upon companies to minimize the exposure to the environment of antibiotic resistance genes that are seen in waste products through the processes of generating the active pharmaceutical ingredients and then subsequent packaging of the medication. And then the economic criteria was often related to if there was requirements around the size of the company or the financial sustainability of the company, because there has been many cases in which certain smaller pharmaceutical companies have brought antibiotics to market and then subsequently gone bankrupt. And this has inherently impacted the supply of these new antibiotics to different markets. Next slide, please. So what are some of the examples of some of the incentives that we identified? So most policy attention has focused on some variation of either a subscription model or an annual revenue guarantee, which are similar types of models, essentially. So Sophie's explained how the UK model works, but they guarantee a certain amount of revenues for a pharmaceutical company if they bring an antibiotic to market that meets their eligibility criteria. That can either be guaranteed to them in the way the UK does, where it's completely delinked from sales volumes and they pay a certain amount of money per year for access to the antibiotic, or in the way that Sweden does it, which is an annual revenue guarantee, where they say that you retain the revenue from selling your volumes of antibiotics. However, if it does not meet a threshold that outlined by us, then we will meet the difference. In some cases, the government may not be required to give a top-up payment, and in others, they may be. So there's lots of benefits to this approach. The amount that so in terms of the certainty and regarding the cost of the incentive, it's relatively straightforward. The payer knows how much they're going to pay for the antibiotic, which allows them to plan accordingly in terms of their budgets. You can also tier that payment according to how valuable that new antibiotic is, and therefore creating a tiered incentive for different types of antibiotics to come to market, as is the way that Sophie has described in the UK model. There is now 4 different tiers. You can also, because these payments are over time, you can make payments conditional on a broad range of different company eligibility criteria. And if the company violates any of these criteria, you can suspend the payments. So it gives the payer a certain amount of power in terms of enforcing specific company criteria. So many other countries are looking at this. So Japan has a pilot model. Canada is looking to develop a model currently. The US has the Pasteur Act, which has been kind of sitting in legislative limbo for quite a few years now. However, there's still, at one point, it did have cross-party support, but seems to have been deprioritized in recent years. And Australia are also looking at implementing a subscription model. The European Commission as well was looking at implementing a subscription model through the Health Emergency Response Authority. Interestingly, they put out a tender for an revenue guarantee, and the company ultimately did not comply with the timings in relation to that tender, so it was never fulfilled. We published a paper outlining how a subscription model could work at the EU level. It's difficult because you have to get 27 different countries to agree to it, and so there's certain political challenges. However, I still think it is feasible. Next slide. Market exclusivity extensions have been used in the US for new antibiotics that meet certain criteria. It's called the Qualified Infectious Disease Product criteria. Essentially, if the antibiotic meets these criteria, then they are allowed to retain market exclusivity for another 5 years. What do I mean by that? So once drugs go off patent, they become subject to generic pricing because other generic manufacturers can start to provide that medicine. These antibiotics are allowed 5 additional years of protection from generic manufacturers entering, impacting their monopoly rights. So the rationale behind this is it can generate more revenues for the pharmaceutical companies that bring antibiotics to market. However, Sophie outlined some of the market failures. Antibiotics are only sold in small volumes and subject to price competition with other generic antibiotics that are operating within the same clinical indication. Therefore, 5 years of additional market exclusivity does not generate that much additional revenue. Therefore, it hasn't really worked as an incentive. Next slide, please. This is the transferable exclusivity extension, often referred to as the voucher, has received lots of attention in the European context. This is essentially allows anyone that brings an antibiotic to market to extend the market exclusivity period for any other product for any other clinical indication by 12 months within the European Economic Area, subject to EMA regulations. This can be applied to any other blockbuster drug with very large revenues. So for example, it could be applied to an oncology drug or an immunotherapy drug that could have revenues of up to 5 billion euros a year. Therefore, the costs to the payer are highly uncertain because we don't know if once it's granted to the market authorization holder, we don't know which other drug it will be applied to. The key aspect as well is it's transferable. So the pharmaceutical company that brings the new antibiotic to market can sell it to another pharmaceutical company. So it could be used for any drug. So the cost, the financial implications are highly uncertain. However, it is relatively easy to implement because it's a regulatory change. Therefore, in the context of trying to get 27 countries to agree to an annual revenue guarantee, other people have argued that a transferable exclusivity extension would provide a high value incentive and influence pharmaceutical industry research and development priorities and be feasible to implement. It is currently included in revisions to the EU pharmaceutical legislation. However, they've not yet been passed. So watch this space. It may happen. Next slide, please. Okay, so this is just a 15-minute presentation, and I suspect I'm already over time. There's not enough time to go through each individual criteria and how it relates to the relative incentives. But the main takeaway message is that the UK and Sweden have the most comprehensive product and eligibility criteria. But every country with an incentive did outline high priority medical need because they often use the WHO priority pathogen list or an adaptation of that to their local context. For example, the CDC has their own priority pathogen list. Canada has their own priority pathogen list. But there was interesting that there was lack of alignment in the specific priority pathogens that were used. The other product criteria were implemented less consistently across different incentive types, but some of these differences relate to the incentive structure. So, for example, if it is just a regulatory change, then it may not necessarily be as explicit in relation to things like health system impact, but the real differences came in the company eligibility criteria. the fact that both the UK and the Sweden have a multi-year subscription and annual revenue guarantee model, it gave them much more power to implement certain eligibility criteria for companies than other incentive types. Next slide, please. So I've already described some of this, but there is significant variation, not just in across the different characteristics and domains that I've outlined, but also within the specific individual priority pathogens that have been highlighted as priorities. In particular, there seems to be a difference in approach between subscription annual revenue guarantees versus other regulatory reforms in how they discuss company eligibility criteria. And there's a need for more convergence and dialogue between different countries in developing their incentives to align their specific eligibility and evaluation criteria. Next slide. So I think that brings me to the end of my presentation. Apologies for overrunning slightly, but I think that brings us to questions now, if I'm correct.
Thank you, yes. So opening up the floor for the Q&A. I guess while we're waiting for questions to trickle in terms of your perspectives, individual perspectives, how do you feel these incentives have been working? How they are pharma companies, do you feel like they are impacted by this? Like, do you see an actual shift, or is it too early in terms of their keenness to develop more into R&D for antibiotics? So I don't know who would like to answer that.
I speak from the local perspective, and then Michael can come in on the bigger picture. I mean, really, really, really good question, Fatima, and it's the question, isn't it? What's the impact of what we're doing? I think it's too early to tell. I mean, everyone knows how long how long it takes to develop, bring a drug to market, from preclinical through to clinical through to launch. So it would probably be too early to assess a shift on drugs coming to market, but there's probably other metrics we can look at. And actually, the NIH are commissioning some work to evaluate the UK model and its success, and working through at the moment what that looks like, what data they can draw on, what the benchmarks of success are, what's within and outside of our control. So there is an independent sort of assessment of the UK model going on, but sort of anecdotally, when we've been engaging with industry, they're really excited by the model and really interested to be part of it in the UK. The impact globally, yet to be seen, I guess.
Okay. Michael, do you want to come in here?
So Sophie's completely right. Ultimately, it's from getting IP rights for a new molecule to bringing it to market, it takes 10 years. So, the UK model, and Sophie may correct me, but I think it was operational from 2019. So it's been 6 years, but
not even. We didn't. Well, it was announced and launched and commitments in 2019, but I mean the first contracts in terms of people wanting to see its worth and followed through. The first contracts in the UK were issued in 2022. So even less time since it's been sort of realised in practice. Yeah.
So 10 years from getting IP rights to bringing in antibiotics to market. So. Although having said that, though, I think the way a lot of these pull incentives work is if you get a substantial enough incentive, it starts to make pharmaceutical companies interested in acquiring small and medium enterprises that have promising candidates. I wouldn't necessarily say it takes 10 years, but it takes years for this to have an impact. There are more. So in the preclinical pipeline, the WHO describes it as innovative. That there are lots of promising molecules with a range of different mechanisms of action that could make a fundamental shift to antibiotic resistance. They describe the clinical pipeline currently as lacking innovation, and the clinical pipeline is not seen as promising. However, there has been a number of antibiotics that have come to market in recent years. The fact that there were candidates for the subscription model is promising. So I do also very interesting to find out there will be an NIH evaluation. So that sounds very promising. I think I think what we'd like to see is the US and the European Commission have a operational, substantially funded pull incentive. I think that will really shift the dial in terms of antibiotic research and development. The other thing to note is that there has been so Kevin's Alston's work is the best estimates that we have. However, it is outdated, and I'm interested to see his updated analysis. I am hopeful and maybe naively optimistic that some of the developments in AI may reduce the costs of antibiotic research and development. So that might make the financial costs associated with an appropriately sized incentive smaller, so that hopefully that could also promote implementation of different incentives globally.
Great, thank you. We also have another question, if it's possible, if these impacts could somehow be translated into academic research. I guess you already touched on that a bit in terms of NIHR. So are there strategies to bridge possible gaps between industrial versus academic antimicrobial research? So I don't know if any of the speakers have any ideas around that.
I mean, there's a lot of initiatives out there, and I can't even claim to know everything that's going on. I mean, there's, for example, one particular hot topic is bacteriophage, right? And the promise of phage products against antimicrobial resistance. And there's huge amounts of work going on through Innovate UK funded projects and others to understand the evidence base and accelerate that and look at the gaps between current research and what's needed to launch a product, bring it to market, use it in the healthcare system. Lots of, I mean, NICE work really closely with NHR on sort of funding research to fill evidence gaps, you know, such as some of the ones highlighted in our pilot projects. So I guess the answer is yes, and I can't claim to know all of the existing initiatives that there are at the moment.
Thank you, Sophie. And does anyone have anything else to add to that, or should we take another question? So there is that question, and that touches upon a bit of what Michael mentioned, that these are impactful incentives for pharma, but they do not seem to be, you not predict to see them working for small biotech who would normally push the early discovery and bring new molecules to preclinical phase. So I don't know if there's any reflections from the speakers on that beyond what was already discussed.
Yeah, so I think generally the policy community seems to accept now that a pull incentive alone is not sufficient to have a sustainable antibiotic research and development pipeline. There seems to be convergence on the fact that a pull incentive should be used to incentivize research and development from phase to clinical trials onwards, and that really we should be continuing to use push incentives, so that's direct grants and research projects and clinical trial networks to try to promote research and development for SMEs and university startups, which ultimately do drive most of the research and development efforts from basic science to preclinical. So I think there's too much uncertainty in relation to what happens between the transition between basic science and projects to different preclinical stages to rely on a pull incentive, because I don't think the risk threshold of many private sector investors are willing to tolerate that. So there is a good economic argument for public subsidization in this space, in that you can say that effective antibiotics should be seen as a public good that we should all enjoy because it betters our society. And I think that builds the economic rationale for continued public investment in push incentives for the SMEs and the university startups in earlier stages.
Great, thank you so much. We're running out of time, unfortunately. So I just wanted you to reflect on one last thing. So we always speak about the national antimicrobial sort of agendas, and different things are being done with different countries. We have these examples of countries that have already started implementing various incentives. Is there more of a role of working more collaboratively across countries and abandoning necessarily like the national agenda and moving towards learning from what is impactful and to tackle antimicrobial resistance? Because I guess different things work in different countries because there are different health systems, but I think there is that role for a movement together, given the risk right now globally.
Absolutely, Fatima. And there's Michael mentioned the transferable exclusivity vouchers, which is being posited as an approach to take as a pan-European approach to a pull incentive. And there were other pilots of sort of pan-European approaches to look beyond the kind of siloed countries working in isolation. So there's definitely efforts to do something pan-European. It's not without challenge because, of course, the different structures and procurement mechanisms and HTA and pricing and reimbursement in different countries makes it really, really challenging. But there's some efforts in Europe and you know, beyond Europe, there's I mean, this is being discussed at UN like high-level meetings, you know, dedicated to AMR and tackling it. And as I said, the Department of Health and Social Care in England has a whole sort of global outreach team to try and foster these kind of international conversations to work more collaboratively on it, because it does need a joined up approach, you're right. And I think there are good efforts in that space, notwithstanding there are some challenges.
Thank you. Thanks, Sophie. Is there anything else anyone wants to add to that before we close?
Well, just to add in terms of the Novel Medicines platform, that this is all about, collaborative approach to work together, including the industry, to put them also on the table. And yeah, so I'm very thankful for the work also Michael has been spearheading. And so thanks also, Michael, for representing the working group within this initiative. And yeah, much appreciated.
Okay, great. Thank you all. It's been great and we've learned a lot, and we hope that the conversation is continued and we are in a place when we reflect on impact, hopefully in a few years. But thank you. And anyone who's interested, the recording will be available on the ERA4TB website. Thank you to everyone who has joined us today. And I will leave you to it. Bye.
Thank you.
Fatima, thank you.